Hello and welcome to the Feeling Good podcast. My name is Fabrice and I'm here with Dr. David Burns, the founder and advocate of the team model. Good morning, David.
Good morning.
I'm glad to have you here for episode 1 of the Feeling Good podcast.
It's kind of exciting. We'll see what happens.
Yeah, we'll see what happens. And so to begin with, since I think a number of people are not familiar with the team model, would you like to tell our audience a little bit about what this is about?
Yeah, we can focus on a couple of aspects. First, what is team therapy? But second, how and why did it evolve?
Right.
And maybe to start out on the second question, I was very excited to be involved in the birth of cognitive therapy way back in the 1970s. I'd been purely in psychopharmacology, and I knew that wasn't working for an awful lot of my patients. And then I heard about cognitive therapy, and I got really excited, although I was skeptical at first, that people could change their thoughts and change their feelings. It seemed kind of simplistic. But I found that by going to Dr. Beck's weekly seminars and trying out, what were at that time very primitive cognitive therapy techniques, a lot of people I'd been stuck with turned it around. They suddenly went from horribly depressed to joy and relief. And I thought, wow, this is something pretty fantastic.
So you were an early student of Aaron Beck.
Yeah, when I was a postdoctoral fellow after my psychiatric residency, and I was doing brain research on the kind of chemical imbalance theory, but I was looking around for some form of psychotherapy to supplement the psychopharmacology, because I just, I was giving out pills by the basketful, and most of my patients weren't improving much. And then the department chairman, John Paul Brady, said, why don't you check out this cognitive therapy? It's something new, and maybe this would be of interest to you. And I said, I don't know. If I saw Dr. Beck, he looked kind of like a con artist, and it just seemed kind of silly. And he said, well, why don't you go to a seminar and just try the techniques out with some of your patients and prove to yourself that they won't work.
Put it in practice.
Yeah. And I said, well, that'd be good. That'd be kind of like an experiment. So I used to go to his weekly seminar. And there were only, I would say, 4 or 5 cognitive therapists in the world at that time. And there was him and 3 or 4 of us who were coming to a seminar. It was in the old state mental hospital, which was right next to the medical school.
So on your, cognitive therapy membership card, it says number 5.
Yeah, something like that. Yeah, absolutely. And but I began to see that there really is something to this. It was my patients that really pushed me into cognitive therapy, because I'd try some techniques I learned in the weekly seminar on someone who was stuck, and they'd say, wow, that's helping me. Do you have some more techniques? I'd say, well, I only have 3 so far. You have to wait another week, and I'll go and learn
another one.
Get another technique. And so it kind of went like that, and eventually I got so excited that I gave up a career in brain research. I had a 5-year grant to develop a brain serotonin laboratory at the University of Pennsylvania Medical School. And I just said, I don't want to spend my life like that. I know that this chemical imbalance theory is not valid. Our research had shown pretty clearly that it was a false theory. And I was excited about helping people. I wanted to see my depressed patients go from despair to joy.
Yeah.
And I occasionally was saying that, and when I started using cognitive therapy, and it blew my mind. So I gave up my academic tenured path at the medical school and went into private practice, and I stayed on the voluntary faculty, which is the same as I'm at Stanford now, and began to develop cognitive therapy. And then I wrote Feeling Good because I wanted patients to have a manual to make it easier to treat them. They could read certain sections of the book between sessions, and then I would kind of individualize the therapy for them. That was my original idea with the book.
And Feeling Good turned into a bestseller.
Yeah, it took 8 years. It was when it came out, I didn't get any support from my publishers. It was hard to get it published in the first place, and then once it was published, they didn't think it had much of a future. But it kept selling and reselling and spread by word of mouth. But then in 1988, 8 years after it was released, I finally got on a national television show, the old Phil Donahue show.
Oh, yeah, I remember.
And within 5 minutes at the end of the show, it went to the top of all the bestseller lists. And that really changed my career a lot and changed the trajectory for that book. It's now sold over 5 million copies in the U.S., and it's been translated all over the world. But
now there's one thing that I'm wondering about is, many people are using cognitive therapy, and this is widespread worldwide. So, and it's been shown to be quite effective for a number of conditions. But I know that you've done some work beyond that, and I think that's what people would be interested in hearing about.
Yeah. Well, a good point. You got me rambling there a little bit. But to make the long and short of it was that cognitive therapy was helpful for a lot of people, but not for everybody. And this was the same that research on cognitive therapy and all other forms of psychotherapy has shown as well, that people who like the techniques and use them would have these fantastic dramatic changes, but there were other patients who kind of yes-butted me and resisted me. Mm-hmm. And the research studies have shown the same thing with every form of psychotherapy for depression, that some people respond, but there's many more that don't. There's been research on my book Feeling Good that showed the same thing. Forrest Gogan from University of Alabama published about 8 controlled outcome studies of depression where the treatment was just giving them my book Feeling Good. Uh-huh. And in all of those studies showed about the same thing. Roughly 2/3 of the patients they gave the book to improved dramatically or recovered within 4 weeks and did not need treatment. These were patients who came to the medical center.
Well, 2/3, that's a pretty big chunk.
Yeah, that was exciting. That's really why Feeling Good has sold so much. It's the most frequently prescribed book for depressed patients by American and Canadian mental health professionals, and probably worldwide it's the same thing. But I kept asking myself, but how about that 1/3 who aren't helped, and the 1/3 in my practice who I struggle with? Why aren't they responding? And if we could figure out why they're stuck, maybe we could evolve cognitive therapy into something even more powerful.
Okay.
And that's actually what gave birth, both through my clinical work and my research. I think we found out why that 1/3 of people who don't respond quickly are stuck.
Okay, and don't keep us on tenterhooks. Why is it?
Well, it has to do with therapeutic resistance, actually, a concept that I had originally kind of scoffed at in my pure cognitive therapy days. But therapists from the time of Freud have talked about resistance, and kind of spiritual, philosophical types have also the Catholic mystic, Jesuit mystic, Anthony de Mello, said we yearn for change, but cling to the familiar.
Right, that's right.
And
I encounter this in my practice all the time.
Yeah, exactly. And so what we've done is to take this vague concept of resistance and break it down into little, easily understandable pieces, various. We've pinpointed the 8 most common forms of therapeutic resistance, and we've developed, with the help of you and Jill Levitt and Matt May and other brilliant colleagues in our weekly training group at Stanford, we've developed 15 or 20 powerful techniques to melt away therapeutic resistance right away the first time I sit down with a person before I try any cognitive therapy techniques or behavioral techniques or interpersonal techniques.
Now, tell me a little bit, how can you deal with resistance if you haven't even started using the techniques?
Well, that's actually not very difficult if you recognize the 8 most common patterns of resistance. if a patient is suffering from depression versus anxiety versus a relationship problem versus habits and addictions, those are 4 different targets, and they're associated with 4 completely different types of resistance. So when you know what kind of problem the patient is asking for help with, you can quickly figure out the most likely types of resistance.
Okay.
And then you can bring them to conscious awareness and melt them away quickly, is what we've found, at least for depression and anxiety. And when you do that, any techniques you use become vastly more powerful. You could think of team therapy as cognitive therapy on steroids. And I'm now seeing patients recover at speeds I would have thought ludicrous or impossible as recently as 10 years ago.
So it sounds to me like you're addressing the resistance before it even happens. Is that right?
That's right. We kind of head it off at the pass. We bring the resistance to conscious awareness, and we use paradoxical techniques and melting it away. We can talk about that in a little bit, but the main cause of therapeutic failure is therapists trying to help patients and trying to sell something.
Well, isn't that what we're in business for?
Well, that's what most of us have been trained to do. But when you try to sell something to someone, there's a natural tendency to resist. So when you go in with someone who's depressed or anxious and say, I've got these wonderful tools to help you, there's a part of the patient's brain that puts up a resistance there and says, well, wait a minute, maybe that's not such a good idea. And then the therapist begins to push, and the patient yes buts, and that's the most common cause of therapeutic failure. And it's actually the therapist's need to help that causes most therapeutic failure. Therapists actually cause the resistance. They intensify the patient's resistance.
So are you saying, in other words, that without this need to help, then there would be no resistance?
It's not quite that simple, but that's certainly a necessary and sufficient condition for the therapist to give up that need to help. Uh-huh. And that's very difficult for therapists. See, I was trained to help.
Same here.
Using these pills that I can prescribe, or this cognitive therapy, or the psychodynamic therapy, or the ACT, or EMDR. Most therapists push to help the patient. And what we're really developed is a new way of sitting back and becoming the patient's subconscious resistance and making the patient aware in a loving and respectful and kindly way, making the patient aware of all the good reasons not to change. And then asking the patient, given all the reasons to maintain the status quo, I'm not convinced we should work on this. Why should we make your depression go away or your anxiety disappear? Do I have the tools to make that happen today? Probably, but I'm not convinced we should, because let's look at all what your depression and anxiety shows about you that's beautiful and awesome. Let's look at all the benefits of the depression and anxiety.
So in a way, it's like you're turning the tables.
Yeah.
Instead of you trying to convince the patient that you can help them and help them feel better, you actually are asking them to convince you that they want to feel better.
Absolutely, but it can't be done in a manipulative way. It can't be done in a gimmicky way. It has to be done with tremendous compassion and accuracy. And when you learn how to do this therapeutically, it's the greatest discovery of my career. It's the greatest development of my career. It's the most powerful psychotherapy technique I think ever developed.
It sounds quite different from a number of modalities that I'm familiar with, but it does remind me of something like motivational interviewing. Are you familiar with that?
Yes, the fellow who created motivational interviewing called me in the early 1980s. He was visiting Penn for, I think, a sabbatical or something. He was working with one of my students there, Joe Wolpicelli, who was an MD, PhD, and a really brilliant guy and a nice guy. And he says, oh, boy, you... At the time, the founder, what's his name, Bill somebody?
I forget.
Yeah. At any rate, he apparently was wanting to create a new psychotherapy approach for addictions.
Addictions, yeah.
And Joe was a full-time addiction researcher there, and I had trained him in psychotherapy as well. And Joe said to him, David Burns has a whole new approach to addictions based on motivation rather than cognition, because I had seen that early on, that you can't use behavioral techniques with addictions, you can't use cognitive techniques with addictions. It's based on cravings and yearnings. And so he called me on the phone. I spoke with him for about an hour and a half and talked about the cost-benefit analysis, the decision-making for him, and how you should approach addictions from a motivational point of view. And then shortly after that, he developed his motivational interviewing and has done very, very well with it. So he has certainly taken a step in that direction. And then the Ericksonians from Phoenix have also attempted to deal with resistance in a paradoxical way.
Okay.
So there are a couple schools of therapy that are moving in this direction, and I certainly applaud both of them.
It seems to be marginal, however. I don't hear that a lot. I see a lot of people coming up with new techniques, but motivation seems to be taking a back seat.
Yes, I totally agree. I totally agree with what you're saying, and I don't want to say that people are suckers, but that really sells well to the community, that you have some new technique to help troubled couples, or you have some new anti-anxiety technique, or you've got your 5 new methods for treating depression or whatever, and therapists are yearning to do that, and it's healthy in a way, because we all want to have some techniques to help people, but unless you deal with the resistance and the motivational issues, your success is going to still be limited, as all the psychotherapy research seems to show, limited efficacy.
So this really all comes down to motivation, which is what you use to address the resistance. Now, you said that you did this because you wanted to improve the efficacy. What has that resulted in?
Well, this isn't purely scientific, but I've started doing live demonstrations in workshops. I used to do them from time to time, but now I have a new trauma workshop. And it's a 2-day workshop, and then the evening of day 1, I always do a demonstration with a volunteer from the audience, someone who's had pretty horrific traumas.
Oh, really? And they're willing to come and do this in front of an audience?
Yes, although I've been recording them, having professional video people come in to videotape them, but then I give them the option afterwards, if it was too personal, you can withdraw consent for doing anything with the audio.
Yeah.
But I've done in the trauma workshop and in my workshops before that, I've probably done 50 live demonstrations in the past couple years. Now, in all fairness, I work with people for 2 hours when I do the live demonstration, so it's like a double therapy session.
Okay.
And in at least 90% of those, I've seen a complete elimination of symptoms in a single session. You saw one that I showed recently at Stanford.
Yeah, I remember that was just very impressive.
Yeah, and I used to see this from time to time in my clinical practice, but now I'm seeing it, almost 100% of the time, and essentially I'm able to complete a course of psychotherapy now in a single session almost all the time, and in a way that leaves little or nothing to be desired. The people are going from really sobbing and severe depression and anxiety at the start of the demonstration to joy and laughter and enlightenment at the end. And I attribute that to the new techniques that we've developed. As I say, we've got to do an outcome study and prove that this is real, and prove that other therapists can learn to get similar results, and that remains to be seen. But it does seem to me to be a pretty fantastic breakthrough in treatment.
Yeah, that seems almost too good to be true. And,
yeah,
and if I hadn't seen the video that you're referring to, I would think that you're just exaggerating, but I
Yeah.
saw it happen on screen, and so that's absolutely amazing.
Yeah, and it's incredibly rewarding for the therapist and for the patient because, I kind of take a Buddhist perspective that we're one, and that you can't give that gift to another person without giving it to yourself at the same time, and it's the headiest thing in the world. And then if you hurt somebody, you hurt yourself. Sometimes I screw up in my teaching or in a demo or something and hurt somebody's feelings, and then I just feel horrible about that. But to come back to the issue here, I believe that the reason I'm seeing these quasi-miraculous results over and over and over again is because we have these powerful, gentle but powerful ways of eliminating the patient's resistance. And when you do that, the patient gets on your team and you're working together and there's nothing holding the patient back. And then it's like you can move mountains when you get that kind of teamwork with the patient.
Well, it sounds to me like this topic of resistance might be a good topic for one of our upcoming podcasts.
Yeah, we can talk about that in the next podcast. What are the 8 forms of therapeutic resistance?
Absolutely.
And what are some of these amazing techniques for reducing or eliminating resistance? And another neat thing is that the resistance in depression and anxiety, the results from the good part of human nature, the positive part of human nature.
Yeah.
Oh, that sound is my little cat, Obi.
That sounds like Obi, yeah.
Yeah.
Well, we'll have to talk about Obi next time.
Yeah, and then the depression and the resistance with the relationship conflicts and habits and addiction, that emanates from the lower forces, the negative part of human nature. But we can get into all those cool topics.
So one question before we wrap up: are any of those videos available?
Not yet. I'm editing them. Well, there's a couple that have become available. I just did a master class for Psychotherapy Networker and PESI on resistance, and I have excerpts from the demonstration last summer at the intensive in the South San Francisco Conference Center with a woman who'd had horrific trauma. Her daughter had been shot in the face, and so we're actually showing excerpts from that video in that class. And then the one I showed at Stanford, the woman who'd been beaten and raped for 35 years, has given me permission to show that video live in workshops or when I'm there for the teaching. I can't distribute it for fear it would end up on the internet and that her ex-husband might see it and then try to get revenge or kill her or something like that. So I have to be very careful with them. But I have a one from Anaheim, California, a live demo there, one from Seattle, one for Portland. I'm getting more and more of these and moving as fast as I can to edit them into some kind of products or packages for mental health professionals and for the general public alike, so they can begin to see how these new techniques work.
Well, I guess we'll have to stay tuned and for an announcement for when those videos will become available.
And that was Obi, if he heard the sound, applauding us with his claws as he rips into our carpet, my carpet here.
So I know we've been talking about the team model during the past 20 minutes, and could you briefly explain what TEAM stands for?
Yeah. It's T stands for testing, and we test patients at the start and end of every therapy session. They do it in the waiting room, so it doesn't waste therapy time. But I've developed brief, highly accurate scales that measure depression, anxiety, anger, suicidal urges, positive feelings, and we ask the patients, how are you feeling at this moment? So when they come into the waiting room, they pull out the brief mood survey. I'm working on an electronic version of it now, too, that they can use on their cell phone. And then when they go in and sit down, the therapist can glance at these scores and see exactly how depressed this person is, how anxious they are, and so forth. At the end of the session, the patient does the same thing. We return the test to them. They sit down in the waiting room and say, how depressed are you at this instant? How anxious are you right now? How suicidal are you right now? And they leave that for the therapist to look at, so the therapist can see for the first time exactly how effective or ineffective you were in every single therapy session. It's like having an emotional x-ray machine available in psychotherapy for the first time, and it has revolutionized the way we practice. Our patients have become our greatest teachers because they know what's working and what's not working.
Well, it sounds like that's another topic for a future podcast.
Oh, absolutely. Absolutely. Then the E stands for empathy. You've got to have an empathic connection, a trusting connection with every patient to be able to work your magic. Now, Carl Rogers said that empathy is the necessary and sufficient condition for personality change. Yes, and you agree, Obi, don't you? People can see Obi on the website, feelinggood.com, and now you can hear him. I'll do a video, I'll get him on video one of these days. Yeah. But empathy, it turned out the research didn't support. Carl Rogers was a great pioneer, and I'm sure he's a magnificent therapist.
Yeah.
But empathy is not going to lead to cure for most patients. But you've got to have trust and warmth to use powerful techniques.
Yeah, that's definitely accepted by all.
Yeah, and so we have some very rigorous, and we can talk about this on a future podcast, also rigorous and exciting, but pretty threatening training techniques for therapists to develop world-class empathy skills. And general public can use these same empathy tools to develop more loving relationships, should they have that interest. That's the E, and so at the beginning of every session, after the therapist looks at those scores, you spend a certain number of minutes empathizing and not trying to help the patient, just form that bond. Now, the A stands for agenda setting, and that's where you bring the patient's resistance to conscious awareness. You see, you can't empathize endlessly and expect recovery.
Okay.
So at a certain point, I ask the patient, once they feel a connection, they feel support, they feel warmth, they feel trust, they feel cared about, and they're kind of relaxed, then I would say, now, is there something you've been talking about that you want some help with? Or did you mainly just kind of want to talk and have me listen and support you? Or are you ready, to do some work? I don't want to jump in before you feel ready.
So it sounds to me like what you're calling agenda setting is that motivational part.
Yeah, because then once the patient says, yes, I would like some help, and you find out what they want help with. I want help with my low self-esteem, or I want help with my panic attacks, or whatever it happens to be. Then we bring the resistance to conscious awareness and melt it away with, we've developed 15 or 20 techniques. We don't need all of those with each patient, but we melt the resistance away. And then after the resistance has been eliminated and the patient is highly motivated to change, then we come in with the M equals methods, TEAM, testing, empathy, agenda setting methods. And in the methods portion, it includes cognitive therapy. I developed many cognitive therapy techniques over the past 30, 40 years, but it also includes behavioral techniques, exposure techniques, interpersonal techniques, gestalt techniques, psychodynamic techniques. You can use methods from any school of therapy.
The arsenal that we can dip into.
Yeah, but I have developed a beginner's toolkit with 50 basic techniques, and the reason you need so many techniques is some techniques work for some problems, like depression, but not other problems. In addition, you have to find the technique that works for each patient, because two patients can have the same problem of panic attacks or troubled marriage or severe depression, and yet the technique that causes their symptoms to vanish might be quite different.
Okay, so TEAM, testing, empathy, agenda setting, and methods.
Right.
Okay. Well, I see that there's more to be unveiled, but that's all the time we have today. So I'd like to really thank you for spending this time with me for this first podcast. And I just would like to tell our audience that if they want more information, they can go to the feelinggood.com website. Is that right?
Absolutely. Yeah, they get information there on workshops, training, online training, books, a variety of resources for therapists and for the general public alike.
All right. Well, thank you so much, David.
Thanks,
and
Fabrice.
We'll see you at the next podcast.
Okay.